Great, good morning, and welcome everyone to the second meeting of Working Group B of the Kansas Senior Care Task Force, and Working Group B is Access to Services. So we'll be talking today about the provision of care for seniors in the state of Kansas who suffer from Alzheimer's disease, dementia, or age-related mental health conditions. So look forward to that conversation. That's a lot. That's a broad topic and a lot to get through. My name is Carrie Bruffett. I'm the facilitator from the Kansas Health Institute joining you today. And a reminder, we'll go around and do introductions here in a second, but even after your initial introduction, when you speak in the meetings, be sure to say your name and your organization if you're asking a question, for example, just so the folks who are watching via YouTube or Harmony can identify us as well, because they can't see we're all tiny little boxes on the YouTube screen, so they can't see everyone's names. So I'm going to share the agenda here real quickly. Hopefully this will do it correctly. There you go. Can you see that all right? So just a reminder of our agenda for today. We'll have everybody self-introduce in a moment. But remember, we have just 90 minutes. We'll have a lot to get through today. The goal of this meeting is to really get to develop the recommendations at the next meeting, which is scheduled right now for next week. This is a pretty quick turnaround for this group. And we'll have two subject matter expert presentations today as well. So you can see, including from one of the task force and working group members, Jamie Gideon, from the Alzheimer's Association. And then we also have Kimberly Reynolds, who is the Assistant Regional Administrator, SAMHSA. Actually, I think your title is something different now. Yeah, okay. I have on another piece of paper, I've got the correct, you are the Public Health Advisor in the Office of the Director of the Division of State and Community Systems Development at the Center for Mental Health Services at SAMHSA. Is that correct? All right. Well, that's the correct title and organization for Kim. So we really look forward to hearing from her. So remember the meeting commitments. We come ready to discuss and compromise, and this is the heavy discussion meeting. The next meeting we can start talking about recommendations. We'll be talking about some compromise. We'll try to keep succinct and on topic, but don't hesitate to ask clarifying questions, particularly this meeting. This is an important meeting. We really want to get sort of level setting on the topics that we're talking about today. And then we do commit to start and end on time. A reminder of the vision statement that you all had discussed last time. Establish and expand a clear path with public policy recommendations for Kansas older adults and caregivers to access services. So hopefully that resonates the same way it did in the first meeting. And with that, I'm going to stop and have folks do some introductions. And in the interest of time, instead of asking a interesting question to introduce ourselves like we did last time, we know that's really great to get to know each other, but we've got a lot to get through today. We'll just ask everybody, say your name and your organization, and just like in one sentence, your interest in this particular topic that we're discussing today, provision of care for seniors with Alzheimer's disease or mental health conditions. And I will go in the order I see folks on my screen. So first I see Annette.
Annette Graham, and I am representing Kansas Association of Area Agencies on Aging, and I'm the director for the Central Plains Area Agency on Aging in the Wichita area. And my interest is to plan for the aging demographics in Kansas and how to best serve that population in the community.
Thanks, Annette. Linda.
I'm Linda Mowbray with Kansas Healthcare Association, Kansas Center for Assisted Living. We represent nursing. Keep access, right care, right place, right time, just like the KDADs, and make sure that those options are available across the state.
Linda, I think we may have lost you. We'll come back and see if we can get your the internet connection. I think we heard your answer though. So, Sarah, co-chair, Sarah.
Hi, I'm Sarah Schlitter. I'm from Johnson County Developmental Services, and I'm representing InterHab. We support adults with intellectual and developmental disabilities. And I think one thing that I would like to just focus on is just how can we best serve the people that we serve in our various programs and brainstorm best practices.
Jan.
Mother-in-law is currently in a facility with dementia. We have other family members who have gone down this road, and here we are again. And we have a lot of experience and a lot of concerns. So that's what. Thank you.
Sorry, I think you're on mute.
Yeah, there we go.
Oh, I was like, everybody must be frozen. My apologies. Dan.
Good morning, everyone. Dan Goodman, Assistant Commissioner for KDAS, Long-Term Care Supports and Services. My interest is largely because this has been a big part of my career, community-based services, and I'm always interested in seeing what we can do to improve or get better.
Hey, Dan, thank you. Jamie.
With the Alzheimer's Association. The answer is in the name of where I work. I am fortunate and blessed enough to work for such a great cause and organization, and also the disease has hit my family pretty hard as well.
Thanks, Jamie. Sean Sullivan. Sean
Sullivan, CEO of Midland Care. Like others, just interested in access to care in all places of the state, to community-based services, and the right care at the right place.
Stacy.
Hi, my name is Stacy Carson. I'm a registered nurse with Johnson County Developmental Supports, and why I'm interested in being here is I've supported a lot of individuals over the years with dementia, and I've seen some things that have worked and seen some things that haven't, and just excited to be part of making some improvements in the services that are provided.
Thank you, Stacy. Tanya.
Good morning. I'm Tanya Dorfbrenner, and I'm the Executive Director of Oral Health Kansas. I'm happy to be joining this group. I'm here because I'm an oral health advocate. We know that access to dental care is a huge part of how people stay healthy overall, and it's also one of the really big challenges for older adults. There's also been a lot of legislative conversation, especially in the House over the last year or so, about looking at the unmet needs of older Kansans related to dental care. So here to be a part of the conversation and help move this forward. Thanks.
Thanks, Tanya. Heather.
Hello, I'm Heather Brown, and I am with Johnson County Developmental Supports, and just have an interest in general on the aging population, dementia, but especially those with intellectual and developmental disabilities. So I am excited to be part of this group.
Thanks. Good morning. I'll also have a couple other folks who have joined us today to help support your work. WAVE. So Sean Marshall with KLRD, Legislative Research Department. And then Emma Urich, my colleague, is co-hosting today, and Charles Peters is co-host as well with the Legislative Office of Information Services. And if we have technical difficulties, you may be able to chat with him. But I know the folks in that office are also doing a lot of multitasking because the legislative session is going on as well. So we appreciate their support. So thanks for everyone's introductions. I think we're ready to go ahead and get started with a couple presentations. I will, before I introduce Jamie, and Emma will bring up her slides to be able to advance those. I'll let you know that we also reached out to Dr. Stephen Benson, who was not available today, but would like to join a future meeting with the group. So we're hopeful that he'll be able to join us soon. He did include the materials, one of the materials that we sent around yesterday afternoon, if you saw it, about the state dementia coordinator position. So that came from Dr. Benson. Linda Farrar was also not available today, but had some thoughts about some of the training programs for Alzheimer's disease and dementia care that we will forward around to the group separately as well. And she may also be able to join a future meeting. But we're really glad to be able to have Jamie and Kim join us today. So with that, I'm going to turn it over to Jamie, who's going to talk about the Alzheimer's Alzheimer's disease state plan.
Okay, thank you. Hello, everybody. So I'll wait till the slides. Okay, here we go. Get started. So I chaired the 2020, it ended in 2020, Alzheimer's disease task force. And this is basically the sole purpose of having the task force was to draft an Alzheimer's disease state plan. At the time, 49 states had already developed an Alzheimer's disease state plan. So we kind of rounded up the end, but we definitely got it done. So I'm just going to start by going through the background. Pull my notes up here. So how it started, really, most people don't realize, but the disease state plan was a two-part plan. The first part began in 2018 when then Governor Coyer signed an executive order creating a working group at the time to draft a state plan. And then in August of 2018, the working group began meeting. And then after several meetings, they drafted, included their work in December of 2018. So it was a very fast turnaround. And the plan was presented to the governor in January of 2019. And then really after that, when the new governor took over, Governor Kelly, she saw that the previous working group had met at a pretty rapid pace due to basically the election to try to get one turned in. She wanted really the work of the task force to continue. So she drafted on May 2nd, 2019, an executive order creating a task force to continue the work of the first working group. And in August of 2019, the task force began to meet. Again, we had several meetings and based a lot of our work off the original state plan from the year before. And then in January of 2020, we presented the state plan to Lieutenant Governor Rogers at the time. And then there were a lot of different task force members from all over the state, from all different connections to the disease. Carrie just mentioned Dr. Stephen Benson. He was one of the members of the task force. But we had people, Annette Graham, who's here on the working group. She was a member of the task force. But we had a lot of different opinions and ideas, and it was really helpful to the work of the group. So I'm going to go into the process of how we drafted the state plan. So first, we broke up into committees similar to this task force. We broke up into several different ones. We had a public awareness work group, access to care, family caregivers, training and workforce, safety and legal, research and data, dementia care, and then rural group. In addition to us having the committees, we also really wanted to get the opinions of more Kansans that were on the task force. So we sent out a survey, and we had a great return on the survey. More than 1,000 Kansans responded from throughout the state. And the typical respondent age was 45 to 64. They were Caucasian, had a bachelor's degree. They lived within the city limits, and 44% had a friend or family member with Alzheimer's. And also 37% were healthcare professionals. So we had a pretty decent mix of healthcare professionals and those with another connection to the disease. So I pulled out, and this is going to be a little bit harder to read, so I apologize, but I did pull out a few of the survey questions to give you an idea of what are some of the opinions we gathered from the survey. And this first one, it asked, what is your opinion on the 3 most critical issues that Kansans should address in the next 5 years? So I'll just pull out the top 3. The top 3 were educate healthcare providers, family caregiver training, and increase access to respite and adult daycare. And those all seem very pertinent to what we're working on here in our group. And then the next question is, when accessing needs for a loved one that may need facility placement, which 3 are the most important to you? And so the top 3 responses were staff training and dementia care, the location, and the cost. In the next survey question, we wanted to ask kind of where, what all was this person trying to juggle at the same time of trying to give for their loved one. And by far, majority were having a full-time job and also being a caregiver, which is a lot on someone's plate. So this next section has to do with the sections of the actual state plan. So we divided it up by, and you'll notice that these titles are the same as the committees that were set. So we had research and data collection, rural Kansas, safety and legal issues, training and workforce, public awareness, access to care, family caregiver, and care for all with dementia. So I pulled out a few just to review today because it's a lot. It's a large document. It's a lot to go over. So I pulled out a few that would be of interest to us here today. And I pulled out training and workforce, family caregiver, access to care, and care for all with dementia. So I'll start with training and workforce. So workforce and training needs span the spectrum from family caregivers who need employer support to professionals in a care setting such as long-term care, post-acute, or hospital care. The needs are evident specifically in the arena of education and communication to better equip those who are in the position to provide care for someone living with dementia. And on the next slide, we go over some of the data regarding training and workforce. Now this is this is pre-pandemic. So all these numbers are just even more enhanced. COVID exacerbated all of this. So again, this is 2019 numbers, but the Kansas Department of Labor lists 20 most difficult positions to fill in Kansas. The number 2, nursing assistants. Number 10, registered nurses. 12, licensed practical nurses. And there's critical shortages. Again, COVID only made this worse. But in Kansas, per the Workforce Data Center, we have 148,000 job openings for personal care aides, home health aides, and nursing assistants between now and 2026. So that number is obviously only increased. And then we move to family caregivers. So Alzheimer's and other dementias rob individuals over time of their ability to process what's going on around them and manage the day-to-day activities of daily living, ADLs, which are both essential and routine aspects of self-care. This creates a unique set of challenges for family caregivers. Then on the next slide, I'm going over a few of the key data here specifically to Kansas regarding caregivers. So there's 85,000 family caregivers in Kansas, and they provide $2.17 billion worth of unpaid care. 1 in 4 dementia caregivers are in the sandwich generation, so they're caring for both someone with dementia and a child or a grandchild. And more than half of the caregivers have been doing this for at least 2 years. So on the next slide, excuse me, on the next slide, it's access to care or care for all with dementia. So access to services, again, this is pertinent to our committee here, varies depending on public and provider awareness. There is much confusion about the prognosis of Alzheimer's disease and what services may be available to help caregivers and families of those with Alzheimer's and other dementias. Caring for a person with Alzheimer's and other dementias is complex and multidimensional. This care is often provided by professional care providers in the community, including, but not limited to, physicians, nurses, residential communities, and other allied health professionals. Individuals with dementia and other families trust that these professional providers meet appropriate quality standards to ensure the best quality care. And then on the next slide, I go over a few different points and recommendations and that are more general that this particular committee had come up with. So we need better ways to understand services, especially specialty services for dementia care. We need access to financial resources, and then increased public education on the disease, case management and coordination of services, need established standards or best practices for care providers, and increased access to quality dementia training for professionals. So then next we have the top recommendations. These are two separate slides of recommendations. There were a lot throughout the entire state plan, actually more than 40, but I pulled out the top 7, I believe, that I wanted to mention to you. The first one is establish the Kansas Alzheimer's Disease Advisory Council. There was a previous bill on that at that time. That's one of the key ones that is mentioned throughout the state plan. And then introduce legislation which would make those under 60 years of age in Kansas with younger onset Alzheimer's or other dementias qualify for services and supports in the Senior Care Act. And then require training for direct care workers, including nurses, that is partnered with financial incentives, like provide, this is something we've talked about, provide loan forgiveness, tuition assistance, academic credit, or a combination thereof for college students who commit to work as a direct care worker for a certain length of time, in order to encourage students to enter the direct care workforce. Now on the next slide, the number 4 is the state of Kansas should create a website that provides a central entry point to link to existing information and resources on Alzheimer's and other dementias. And then next is family caregiver training. Create a tax incentive for family caregivers once they complete the training course successfully and obtain a certificate of completion. A state-endorsed program and incentives would expand caregivers' knowledge and skill sets for this very special and challenging circumstances. And the next one is required training of adult protective services workers and law enforcement personnel regarding the recognition of individuals with cognitive impairment, effective intervention in cases involving the abuse and exploitation of individuals who are cognitively impaired, and securing the safety of abused and exploited individuals with dementia. And the last one listed here is provide funding for Alzheimer's specific respite programs at appropriate levels, regardless of an individual's age or financial status, by increasing funding of area agencies on aging so as to assist in dementia caregiver services. I know that's a lot to go over, but those are the top 7 that were most common throughout the Alzheimer's state plan. So that completes my presentation on the state plan. I know I went through that fairly fast, but there was a lot to get into, and I could take 2 days explaining it. So any questions?
Questions or discussion from the group? We'll have an opportunity to discuss in the next section as well, but any questions for Jamie about any of the recommendations or any of the findings?
Jamie, this is Tanya Dorfruner from Oral Health Kansas. Could you go back a slide? I was curious. I wanted to look again at the APS description. I think that's interesting because that's important. So thank you. I just wanted to take another look at that. Thank you.
Right. I had talked with APS workers at the time, and for the most part, their only training specific to dementia was one slide of a PowerPoint when they first began work there. So they didn't really have, this was at the time, much training at all.
Sounds like a great recommendation. Thank you. I appreciate your indulgence. Thanks.
Mm-hmm.
All right. Thank you, Jamie.
Sure. Thank you.
Look forward to the discussion. So, yeah, there's some comments as well about funding for Senior Care Act and the kind of things that Senior Care Act would do. And I know in a minute when we look at some of the recommendations that were discussed in the task force that are related to this, that'll be an issue that we talk about as well. So, and now I'm going to go ahead and introduce Kim Reynolds again to present to us, and she's going to talk about the behavioral health needs of older adults. So I think we've got her slides as well. And so Emma, I think you can go ahead and share and take it away, Kim.
Thanks. Good morning. I'm kind of looking for the slides here. Here we go. Thank you for running those. So again, I'm with SAMHSA, the Substance Abuse and Mental Health Services Administration, in our Center for Mental Health Services Division of State and Community Systems Development. Next slide, please. So we are the agency within the U.S. Department of Health and Human Services that leads the public health efforts to advance the behavioral health of the nation. And so when I talk about behavioral health, I am talking about mental illness and substance use disorders. And as it says on the slide, we know that that behavioral health is essential to health, that prevention works, that treatment is effective, and that people of any age can and do recover. Next slide, please. So just quickly, a mental illness is a disorder that affects a person's mood, thinking, or behavior, and they can range from mild to severe. A mental illness that substantially interferes with a person's life and ability to function is called a serious mental illness. And that would be like bipolar disorder, major depressive disorder, schizophrenia, conditions like that. So at SAMHSA, when we want to look at the prevalence of mental illness in a population, we turn to a survey that we call NSDA, or the National Survey of Drug Use and Health, that actually surveys about a variety of conditions. Right now, we're surveying between 60 and 70,000 people a year in all 50 states and DC. And we've been conducting that survey since 1971. And so I provided for you a couple of figures right out of our report for 2019, where they did a summary of from 2008 to 2019. So if you can look at the older adult line there, it shows a relatively kind of a stable number over that 11-year period. When we look at the 2020 data, there is a slight increase. So for example, for any mental illness in 2019, that was 14.1%, whereas in 2020 it was 14.5%. For serious mental illness, it was 2.9%, versus in 2020, 3.4%. But because of the pandemic, the way that the data needed to be collected for 2020 was different. And so we have recommended caution in making comparisons of our 2020 data, and that's why it's not on the slide. But there have been analyses by everybody from AARP to WebMD that have specifically examined older adult mental health during 2020 and 2021. And some of those have indicated an increase in mental health problems that might be associated with the pandemic. Next slide, please. So those impacts by the pandemic on older adult mental health could include social effects, emotional effects, and behavioral effects. Next slide, please. So regardless of the impacts of the pandemic, we know that there have been and continue to be a proportion of older adults who experience symptoms of mental illness, and that while most older adults prefer to age in place, those symptoms may impact their ability to do so. And I want to be clear and say that depression and anxiety disorders are not a normal, inevitable part of aging, and that they are treatable and that people can and do recover. So for those who may be experiencing a mental health problem, they may benefit from accessing the mental health system in their community, like a community mental health center, for example, which typically provides outpatient services such as individual and group therapy, access to a psychiatrist, crisis stabilization, and peer services, among others. And additional services like case management tend to be available for folks with a serious mental illness as well. States and communities do vary in their availability of targeted services for older adults that are provided by clinicians and paraprofessionals who are trained in serving this population. And the lack of neuropsychiatrists and other aging specialists is a barrier to older adults seeking and receiving culturally competent services. So some older adults may receive medication and other resources through their primary care providers, and others through aging service providers. So for example, Annette Graham's AAA has hired a clinical social worker who provides individual and group therapy and other kinds of services to her older adult clients. So, but I wanted to highlight that one of the ways that you can find services in your area is through our treatment locator. So while that's not older adult specific, that would tell you about treatment services that are available in the geographic area. And so for this example, I plugged in Wichita, Kansas. I said within 25 miles of Wichita, and then I selected both mental health and substance use services. And you can see that return 49 different providers. They're also on the map. And then if we were to click on them, that you could drill down further and see, what are the populations they serve, what kind of services do they provide, reimbursement possibilities, that sort of thing. Next slide, please. So to support states, tribes, clinicians, family members, and older adults themselves who might be experiencing a mental health problem, SAMHSA has a variety of resources. So these are some examples of toolkits and guides that we have developed that are specifically about older adult behavioral health. Next slide, please. We also have a web page on our website that has links to publications, has working papers, information about different resources that are available. Next slide, please. SAMHSA also funds a variety of training and technical assistance centers around the country on a variety of topics. And so recently, one of the topics on which a national center was funded is the is around behavioral health disparities in aging. And so this center of excellence, that's called the E4 Center, is at Rush University in Chicago, and they have developed already a plethora of webinars and toolkits, white papers, different kinds of trainings. They're doing some policy academies around the country. They just have so many resources that are available on their website, and they are available for some technical assistance to stakeholders who request it as well. Next slide, please. In addition, the Health and Human Services divides the country into 10 regions, Kansas being one of the states in Region 7. Within the Region 7 HHS office are regional administrators and assistant regional administrators. In Region 7, the regional administrator is Kim Nelson, another Kim. And she is available to talk about, local regional resources and initiatives, and to provide more detailed information about, things that are happening within SAMHSA, and so would be an ongoing resource for you. Next slide, please. And then finally, I want to mention the National Mental Health and Aging Coalition, and that a link to that website is listed on the slide. In Kansas, there are also a couple of local mental health and aging coalitions. In Sedgwick County, you could speak with Annette Graham about that coalition. In Eastern Kansas, that would be Nancy Luber. In the past, Kansas has also had a Kansas Mental Health and Aging Coalition. I think that may be somewhat dormant, but Annette would certainly be an expert who could kind of tell you where things are with that coalition. And then the last slide, please. So here is my contact information. If you have questions after today, or if I can provide you with additional information, please do reach out to me. And again, thanks for having me come and speak with you today.
Thank you, Kim. Yeah, and there's multiple Kims that we can reach out to at SAMHSA that are great resources for Kansas. That's wonderful. How about questions for Kim? Questions about any of the data that she presented or any of the federal programs?
This is Annette Graham with Kansas Association of Area Agencies on Aging. And I was just wondering, Kim, do you have any information or data on the percentage of older adults who don't seek or don't utilize treatment for their mental health issues?
I don't have age-specific data, but I can go back to the NSDA data and find that number for you, Annette, and then provide that to you at a later date.
Thank you.
Anyone else have questions? Kim may be able to stay on for some of our discussion as well. I think I had a comment that received from Jan, that community mental health center model in communities across rural Kansas have, in some places, have shut down in communities, and there's not the replacement services added. Have you seen that impact, Kim? That some of the, maybe not just in Kansas, but sort of regionally, whether it's related to COVID-19 or otherwise, is there an impact on the availability of services?
I think that there has been an impact across the country, really. that is related to COVID currently. And I think, rural areas have their own challenges as well. I think there are a lot of new opportunities, though, that are coming with some of the American Rescue Plan and COVID funding for communities to develop services across the lifespan, crisis services and other kinds of services. And so hopefully that, that will help to kind of mitigate some of those issues.
All right. Well, thank you very much. Thank you to both of you. This great information and very helpful, I think, as the working group starts to pivot towards thinking about recommendations, is to really understand the scope and scale of I would say the issue, but it's multiple issues. Dementia, Alzheimer's, sort of distinct, even though there's some overlapping challenges when talking also about behavioral health for older adults as well. But those are also distinct challenges, and they all are in this discussion topic for you all in this meeting. So I'm going to go back and share my screen for a moment and for a few moments. Y'all see that? So this is, you also received, probably may not have had a chance to look at it because it came out late yesterday afternoon, a matrix or a list of some of the recommendations that had been discussed in the task force. I'll zoom in a little bit more. Looks like some people are straining in to read it. There we go. That had been discussed either in September or some of the meetings. So this is derived from a list that the Legislative Research Department keeps track of, but we modified it a little bit and really thought about which working groups, because many of these recommendations were assigned out to working groups to discuss. So it's at the very least a starting point for you all when you start to talk about recommendations and really develop, and you may want to develop additional recommendations or revise recommendations in your discussions. So I put a little asterisk in a few of the meeting notes box just to thinking that, and these are all the recommendations that there were some that were signed out, and then we also had the co-chairs of each of the working groups sort of took a shot at, for those that were unassigned, it was just like some working group look at it, at volunteering their working group to look at particular issues. Some were pretty clearly fitting within working group B or working group A or the workforce subgroup. So we did remove those recommendations that were adopted by the task force. For example, there was an adoption about KDAD's reaching out to a university partner to develop mapping. So if that's something you all still want to talk about, you can, but that was something that the task force had already taken some action on. So with that, I thought we might take an opportunity to see if people could look at these recommendations, see if it sparks other discussion, and see maybe what's missing, and you can start to think about what recommendations you may want to be discussing in your next meeting. And at the end of this meeting, we'll talk about a tool that we'll be asking you to use between this meeting and our next one. And then we'll also use in the next meeting to develop other recommendations based on your SWOT analysis you did last time, the strengths, weaknesses, opportunities, and threats analysis. The first one, though, I saw was, and it linked to a comment that I saw as Jamie was presenting, was creating a separate Senior Care Act-like program to provide services to persons with younger onset Alzheimer's disease, with its own funding allocation that would go solely to that population, consider the specialized services needed that would be different for this population. This didn't have a name associated with it, so I'm not sure which member it came, who had submitted the recommendation, but I didn't know if anybody wanted to chat just really briefly about where this recommendation came from. If you think there's anything we talked about this morning or you all talked about this morning that you'd want to enhance this with, again, we don't need to refine the recommendation, just discuss what would be valuable to understand about it. So when you actually start digging into it, you'll have all the information you need.
This is Annette Graham and the Kansas Association of Area Agencies on Aging, and I have made that recommendation. But I did just want to also mention that I think it was the final day of our task force meeting in December that the definition of senior was established in the task force, and that set that at age 60. So I think that kind of impacts this. Now, understand that Senior Care Act program currently serves individuals age 60 and older. So, that will impact that recommendation, because the work of this task force, according to the definition, would be 60 and older.
Okay. So what you're saying for this particular recommendation, perhaps not relevant to the task force's work because of that definition. All right. Thanks, Annette. That's very helpful. So the next one we saw, and there are several others, and I don't mean to skip over the recommendations. You'll have a chance to look at all of these in other meetings when you're looking at other issues as well. The next one that seemed tied, and maybe this was also related to the mapping question, but Linda, this is one that you had talked about, which is the state identifying geropsych services resources. I don't know, it was in a list of recommendations, including some about mapping. So I don't know if this is a broader recommendation or discussion, or if it was related specifically to the mapping of those services. Linda?
Linda
Yeah.
Mowbray, Kansas Healthcare Association. Can you hear me all right?
Yes.
Okay, thank you. This was looking at identifying resources, not only geographically for geropsych services, but also what are their settings that they're practicing in? Are they clinics? Can they go into our long-term care settings? You know, is it telemedicine? Just basically trying to identify our geropsychiatric resources that are available across the state, and then being able to plug those that need those services into something that's local or that can perhaps come to them. I think you're on mute, Gary.
I am. So you would say this is broader than mapping. This really is about almost matching, a resource matching identification. And so this is a recommendation you'd want this group to talk about.
Yes, it is. And also for identifying parts of the state that may be underserved, and into that broader workforce issue of bringing those resources in to help mitigate those gaps.
Great, thank you. Any other thoughts about this one or comments on this idea or any other information you want to have for a future discussion? Okay. I'm going to keep myself off mute because when I put myself on mute, I'm trying to be polite and I keep forgetting to unmute. So I apologize. If you start to hear any feedback, let me know and I'll remute. The next two recommendations, Linda, you could probably speak to as well. They were related and similar about expanding funding for aging mental health specialists at all CMHCs, and funding for aging specialists at CMHCs. So thoughts or discussion, or what would be helpful information to have as you start working on the recommendations about this particular one?
All right, Linda Mowbray, Kansas Healthcare Association. The thought is, as we combine the community mental health centers in with our aging population, making sure that we have specialists that can identify differences between mental health issues and dementia-related issues. If there are dual diagnoses, how are things overlapping? Just making sure that we have the specialists that the individual needs to care for, that person. And then looking at how do we fund that so that the CMHCs could have that aging specialist, and perhaps tying back into the geropsychology resources and whatnot, so that we get the right care for the individual for their particular circumstances.
Discussion or maybe thoughts on what information might be helpful or who you'd like to hear from about this kind of recommendation?
This is Annette Graham, Kansas Association of Area Agencies on Aging. In the first one, it talks about expanding funding. I'm not sure, and we would probably want to check, but I don't know that there's any funding specific to funding for mental health specialists, for aging mental health specialists. So I think it would be providing that funding working with the older adults with mental health issues is very complicated and complex. You have to understand normal aging and abnormal aging. You have to be able to do the differential diagnosis between dementias, mental health issues, and the physical health. There's a lot of comorbid conditions, health conditions, and medication that impact the presentation for an older adult. So there's a lot of specialization. So I think, just learning more about it, is there training, which mental health which providers have aging specialists, where those gaps are. And then I think one of our later recommendations relates to training. So there's definitely, you would have to fund it, encourage mental health centers to have that aging specialist, but you'll also need specialized training for those people. So I think that's a combined recommendation.
Great, thank you. Jan, did you have a comment that you wanted to add about the previous one or this?
Kansas Silver-Haired Legislature, Morris County representative. The issues that we see in this most recent examples of lack of geropsych physicians and personnel, and especially, for example, the last time we were trying geropsych with our loved one, the geropsych was at the University of Kansas Medical Center in Kansas, and she's out in Northwest Kansas. And the only way to do that is telemed. And somebody has to take her from the nursing home over to the hospital. Is the only place they could get a connection. It was just not good. And then the geropsych person, as nice as she was, had the audacity to retire, and they didn't replace her position. And so there's not been one available to our loved one. It's bad. It's not good, and I am concerned.
Thanks, Jan. So I'm trying to capture basically maybe dependent upon telehealth in rural areas, and even then may not have good access.
Right. Can't get it in the facilities. There's not available staff to take her over there. I mean, there's a myriad of excuses, but she's still not getting that particular component that would be so helpful.
Thank you. So to Annette's question, perhaps we can follow up, and Dan, we can follow up with KDAD's, the behavioral health folks too, to confirm that issue that Annette said, which was, is there any funding that's specific to aging mental health specialists, as opposed to it's funding that if it's provided, it has to be covered under all the rest of the funding and resources the community mental health centers may have. Okay. Another one that we saw, are we done with the conversations and with here? Are there other, again, part of what we're trying to accomplish here is making sure we all understand what the recommendation is. And then if you want some additional information before the next meeting, when you're really going to be helping develop other recommendations or refining these, just let us know. But that funding question seems like a key one.
This is Linda Mowbray with Kansas Healthcare. There are a couple of comments in the chat that I think might be worth noting about some of the challenges again, and Jan spoke to some of them, but I think they're good points to discuss.
Yes, Jan says COVID only intensifies the problem. Lack of mental health services and Alzheimer's support has been a longstanding issue. And she spoke to the geropsych as well. So thanks. I tried to capture some of this as well. Because we're on live stream with comments, you can add those, and we'll try to remind me that they're there so I can read those, because the folks that are watching the live stream can't see the chat messages. So we want to make sure that they are able to see everything. So most of our comments we want to say out loud. So let me make sure that I didn't miss any others that we'll need to read. I talked about Jan about the community mental health center model. Jan had earlier said, funding from the Senior Care Act needs to be significantly increased if we're going to add more tasks they are to handle. A Reminder too that this group is going to be talking about the Senior Care Act specifically in future meetings as well. All right.
Carrie, Sean
Go ahead,
Sullivan,
Sean.
Midland Care. I wonder if we can get from either Alzheimer's Association or even one of the provider associations a sharing of best practices or highlighting the best practices of pairing geropsych resources. There's becoming more and more access to telepsychiatry services and geropsych services. We are starting to use them in the PACE program across the state, but there is a challenge of trying to pair that with local boots on the ground resources. So if anyone has that figured out or can identify best practices here in other states, whether that's SAMHSA or other, that'd be good for the group to hear.
Sean, I'm sorry. Will you restate the pairing of what and what? I was starting to type and didn't do a good job.
Sure. I was stating there's a proliferation of access or greater access of telepsychiatry and geropsychiatric services. Sometimes the challenge with that is pairing those with local resources, whether it be through a safety net clinic or someone at a local clinic that can be there with the older adult. So that's more the challenge I was speaking out of best practice with that.
Thank you. Okay. One of the next recommendations that the task force talked about that is related to this issue was establishing mechanisms. This is from Ernie Cutzley, who's not on this working group. The state should establish mechanisms to ensure that long-term services and supports agencies and mental health authorities address the mental health needs of individuals receiving LTSS. Now that's that's probably very aligned with the charge, right, for the group, but let's look at some of his comments and see if there's anything you all would want to follow up on specifically. That state government should ensure people with dementia and other mental disorders receive necessary treatment and LTSS in the most appropriate and integrated setting of their choice. That's a little different too. That kind of really sort of balancing and the availability of those services for home and community-based services, not just in facility. And then supporting efforts to reduce and prevent inappropriate use of antipsychotic medications, which another working group is working on, working group A, as a means of chemical restraint. So there's a kind of a mix of this recommendation between probably this working group and the other. Is there anything specific that kind of calls out to you in this language that you all would want to follow up on? Okay. I'm going to scroll down to the next few. There's 3 more that we identified from here, and Annette and Linda and Jamie. Good, they're all here and they can talk about them as well. So the first one, Annette, is requiring CMHCs to provide mental health and aging training for clinical staff who provide services. You mentioned this earlier, so that ties to that other recommendation, but you want to talk about this a little bit more?
Annette Graham, Kansas Association of Area Agencies on Aging. And yeah, I did kind of reference this in the above things. So what we have seen across the state that many of the mental health centers no longer have aging specialists. 10 years ago, we saw a lot more aging specialists in the arena, but we don't see that anymore, and there's a scarcity of that. So we do know that they do provide some services to older adults and kind of address that. If you're not going to have aging specialists, then you really need to be providing training to your staff who are doing that work to understand the specialized service needs for this older adult population. Like I said, it's a very complex population to deal with, a lot of comorbidity and other issues impacting. And if it's not appropriate care, then it's not going to be very successful. And it's also, people have to really be able to relate to a therapist when they're getting clinical services, or they're not going to come back. They're not going to seek out those services. And there is a scarcity of mental health and aging training. Kim had referenced the state, we used to have a very active state mental health and aging coalition, and I had been involved with it, and Kim had also previously. That is no longer functioning. We have talked about Nancy Trout, who's an aging clinician, and I have talked about efforts to try to revive that. COVID has kind of put a damper on that at this point in time, but I think that's something that could be in the future looked at. And then
what was that called?
The Kansas Mental Health and Aging Coalition.
Mental health. Who are members of that? Mental health in aging?
We had a variety of members. We had members from NAMI. We had members across the state, clinicians, some hospice organizations. So it was a pretty broad base. But one of the key features of our Kansas Mental Health and Aging Coalition that had always been in place, because that had a long history, had been around for many, many years, was that there were always consumers on that coalition. Unlike some of the other state models, it always had other members, that peers and support groups. So it is something that we would like to, and we had some universities, University of Kansas, we had some, Kansas Newman was a member, so it was a very broad base, but it is something we have talked about reconstructing and getting back in place. That would be a resource for training if we could get that back and running.
Thank you. Linda, I'll come back to yours, but because Jamie's is well, it's training related. I guess it's dementia training, not mental health training related. But Jamie, do you want to talk about providing the dementia training? And you have some specificity here about a number of hours and so on. Is this derived from sort of best practices?
Yes, it's a national recommendation because Kansas doesn't have any dementia-specific state training requirements, and that's desperately needed. Most states now have some sort of requirements, and it varies on who and the amount of hours. But this is best practice of having 4 hours of dementia training annually for direct care workers, and then it lists examples of direct care workers, nurse aide, med aide, and then 2 hours of training for any new employees in their first 90 days of employment. That will dramatically help those that are trying to, it would help the employee and the employer as well. Plus, obviously, the main goal is to be able to take care of the resident properly.
Thanks. See a comment as well that I'll read. Sarah, say it's also an issue for those that you all support that have dual or multiple diagnoses, IDD or brain injury, etc. Sometimes even clinical staff don't understand how to best support and provide services for those with dual diagnoses. So I can add that about dual diagnosis. Where does that make the most sense, Sarah? Where would you, do you think that's a separate, distinct potential recommendation, or where does that fit here to make sure we don't lose that?
Well, I was thinking when you were talking about the requiring CMHCs to provide mental health training, just because sometimes when people have dual diagnosis, it seems like even clinical staff have difficulty knowing how best to support.
Yeah. Right. Any thoughts or discussion around the dementia training or the mental health and aging training? Any sources of information that you would like to see before you start digging into the recommendation?
The Mowbray Kansas Healthcare Association. CMS has training available at no charge called Hand in Hand, and it is a well-received training program that many have voluntarily gone through, but it's already created and out there.
That was one that Linda Farrar pointed to. So we will also send some of her comments to you all, but that had a link to Hand in Hand. She provided a link to that as well. Jan.
Where we live, Jan Kimbrell's Silver Legislator, Morris County. Where we live currently, there had been an attempt to bring a speaker on dementia training into our community senior agency, our senior center. And it was very well attended. This is right before COVID, so we haven't had those since, but it looked to me like we could take advantage of the senior centers that are in almost every small community, and to bring in those folks who could train the caregivers there. It seems like an opportunity that we're not using, and I mean, they're already there. The mental health center's not there in the community, but there's a senior center, and if we could get folks to come out to train, I think at least in my baby boomer generation type folks thinking we would come and we would learn, and then we could help. And
thanks, Jan.
yes.
Okay, now about providing access for residents with level 2 mental health needs that could be provided in the nursing home by a community mental health center. Linda, do you want to talk about this one?
Yeah, Linda Mowbray, Kansas Healthcare Association. Just as a little bit of background, when an individual chooses to go into a nursing home, there's an assessment that's done prior to coming in. It's called a care assessment. And part of that is a screening for mental health needs. They call it PASSAR, and it's mental health, developmental disabilities. It really looks at what's going on with the individual besides their physical needs, why they might be coming into the nursing home. And if they trigger any kind of mental health needs on that assessment, then there is what's called a level 2. And with that level 2 assessment, the assessor puts recommendations into place so that the individual's mental health needs can be met along with their physical needs while they are in that nursing home setting. And it may be that they're just there for a short term, or it may be that they're going to be there for, 6 months, a year, or longer. But those recommendations that are made on the level 2 assessment are sometimes very difficult to provide in the long-term care setting. So the thought was, can we have funding for the CMHCs to come into the nursing homes to help provide those specialized services and recommendations? And if not the CMHCs, what are the other resources out there so that individuals who are in long-term care with mental health needs receive the treatment, therapy, etc., that they deserve and that's been recommended for them? Sorry, that's a very lengthy explanation, but I know not everyone's familiar with the care process and pre-admission.
So the issue is now to allow it to be provided in a nursing home by a CMHC, and that is not allowed now because that's considered a well, it's not that it's not allowed, but it's not allowed it to be reimbursed separately. Is that the issue? That it's considered sort of a nursing facility content of service, or what's? Please remind me the rest of that.
This is Linda Mowbray, Kansas Healthcare. I'd have to ask the CMHCs for further clarification, but typically their services as community mental health centers don't provide services coming into institutional settings. And what I guess I'm looking for is funding and access to those experts that would be able to come in and help provide services.
Would it be helpful then to perhaps for this group to understand what those barriers are for those services being provided now? Maybe that's something we could follow up both with the agency, Dan, we can follow up and with the CMHC Association as well with that question. We'll do that. No, Dan's there. Okay. Dan, we'll follow up with you about that as well.
Carrie, Linda Mowbray, Kansas Healthcare
Yes.
Association. The other incentive of hooking the CMHC up while the individual is in a nursing facility would be the pre-lawsuit litigation settlement, whatnot, of trying to get people with mental illness back into the community. This would actually hook them up with the CMHC at a much earlier level that might help facilitate that discharge.
Yeah. Okay, are there other recommendations or maybe some things that we saw on Jamie's slides or Jamie that you talked about for recommendations from the work of the working group, the state working group, Alzheimer's and Dementia State Working Group, that could be added to this list? They wouldn't be senior task force recommendations, but this is the opportunity to also talk about other groups' recommendations. Would it be helpful to call that screen up, or are there any, Jamie, that you think that aren't really identified here that would be helpful for this group to be looking at?
One initially comes to mind. It also can be tied to the attachment that was sent yesterday by Dr. Stephen Benson. So the two most common recommendations through the Alzheimer's State Plan were first a creation of an Alzheimer's Disease Council. But you can join that with, which is what Dr. Stephen Benson sent, a Alzheimer's disease coordinator for the state. So a part of or separate from either one. States have done it differently, but to create that, and basically this would be not a temporary council, it would be a permanent council that would meet. And what they would do is they would be responsible for creating a new Alzheimer's disease plan, which is recommended to reevaluate every 3 to 4 years. And also address any changing needs, which Kansas would have each year, and present a report to the state legislature, as well as the governor.
Great. Jamie, do you see those as the same if we were to, are those distinct, having the council and the coordinator, or are those, do those to go together?
They can go together. They can have a council with a coordinator from the state. There have also been ones where they've just had a council and not a coordinator, or vice versa, where they've had only a coordinator in the state, but no council that exists. But I have seen where they have both. So that's why I just kind of threw both in there.
Great. That's good. All right. Annette?
Association of Area Agencies on Aging. Kind of in reference to some of the materials presented by Jamie in her presentation was the issue about training and training for family caregivers and respite care. I've been in communication recently with Gina Irve. She's done a lot of work around respite care and training, and there used to be a respite care coalition in Kansas that's no longer in operation, but she has worked to develop a database for respite care providers. People can sign up and then people can go to that website. Right now, that is available through the 3 MCOs. They have access to that database. And for those respite care providers, it's individuals. At this point in time through that process, if you're a participant of an MCO, the participant can go to that website and find a caregiver, kind of a match up with a care provider for that respite care service, and then the MCO will cover the cost of the background check. It's also available, I think, to others, but they have to pay a monthly fee to access that.
Mhm.
But one of the things she's been working on is working with a group out of, I think it's an association out of Wisconsin, and they are developing some respite care training. That might be something we want to look at. I got something late yesterday, and I haven't really had time to fully go through it, but it looks like that respite care training might be available in Kansas. They might have made that available. So
Oh,
we
okay.
might need to, if people are interested in that, look at having her come and present sometime about that resource and about that database. That might be helpful.
Dan, is this, go ahead.
I was just going to jump in with what Annette was saying. That is also one of the recommendations in the Alzheimer's state plan. But in addition to that, Robert Miller out of Wichita, he is familiar with actually a model that is occurring now, where they are working out of a high school and they are training family caregivers right now, and that model can be replicated throughout the state. But it's happening now and here in Kansas. So if that we can use that particular model, but Robert Miller from Wichita is familiar with that, and I can give you his contact information, Carrie, if you need that.
Yes, thank you. Dan, I was going to ask, in yesterday's workforce meeting, there was some discussion about the registry and what you had. I saw your email this morning, so I also recognize the name Gina Irve. So is this the same registry we're talking about? Yeah.
Yeah, I believe it is, and obviously there's potentially another resource there. Maybe that's who Annette was referring to, but Advancing States may be the group that she's referring to out of Wisconsin. I don't know. I don't know if that's the same group, but
Yes,
sounds like both groups are interested in that. In them.
I always remember it's ED, the capital Advancing States, because it's aging and disabilities, but it autocorrects every time. Well, I had a to-do in one of our previous meetings to reach out to Advancing States for a subsequent topic when we're talking about rebalancing and so on. So I could do some follow-up as well. Okay.
Yes. Kansas Association, and I can, area agencies on aging. I have that contact information, and I can get that to you from with Gina Irve.
Thank you. Okay, anyone have other thoughts or other information that would be helpful? If not, we can switch gears so you can understand kind of what the next meeting is going to be, because just a reminder of our SWOT analysis. So this is the result of the first meeting you all had, when we took only about 8 to 10 minutes per topic, if you remember, and spent some time thinking about strengths, weaknesses, opportunities, and threats for the various topics that this working group is going to be taking on. Let me zoom out a little bit so you can see the whole screen. There we go. And this was the outcome. So just take a second to look at this. Oh, am I sharing my screen? Can you all see this? Okay, good. And take a second to look at it, and we will send this out with a tool that we'll also share with you in a minute that I'll ask Emma to share between now and the next meeting, because we'll be using the results of this SWOT analysis to help think and ask you to help think about potential other recommendations or new recommendations that may not address, that may be different or address different challenges and opportunities and threats, etc., than what we've talked about so far that came out of the task force or from the state plan. So one of the things we're going to ask you to do is see if there is something you'd want to add now that you can have a little bit more time, not just that about 10 minutes of a rush that we were asking you to use a Google Jamboard to do. If you would add other strengths, weaknesses, opportunities, or threats, or if maybe something was accidentally put in one column that should have been somewhere else. So that can happen sometimes. We're all using the sticky notes as well. So take a second to look at this and see if, based on what we've talked about today, if there's anything you see that's really missing from here that you would want to add to any of these columns, either strengths, weaknesses, opportunities, or threats.
This is Sarah Schlitter from Johnson County Developmental Supports, and it's true, but I wonder, I know we've talked about it before, but maybe having more legislative flexibility in terms of services and programming. And so maybe that's just encompassed in that weakness one.
Need more flexibility, basically?
Need more or continued. I think we had discussed in one of the days in Topeka about, you know, how during COVID we have done some things or seen some have worked, and maybe having that be able to be continued flexibility post pandemic.
Like hit this? Yeah. Thank you. I captured that correctly, kind of right under the, I can't figure out how to easily make that a sub bullet, but it sort of falls right under the no flexibility. Instead, it may be perhaps, and maybe even that's the opportunity. Maybe there's some opportunity because of what's been learned during the pandemic to be able to continue that flexibility.
Yeah, that was what I was thinking. Thank you.
Yeah, thank you. Jan, I see your hand raised.
Thank you. Maybe it's here, but the idea of the development of the state Alzheimer's plan that we were talking about a few minutes ago, I don't quite see it here named that way. Is it in there and I'm missing it? But I would want to be sure that there's some, that is such an excellent idea that needs to get started now. And we should, Kansas is the only state that doesn't have one. I mean, that's alarming, and it's time to fix that problem. And so I'm not sure I see it addressed that way. It's here, but.
Right. So there's the 2020, maybe Jamie, if you want to talk about that, we show it as a strength in having the plan, but maybe you're talking about the council debate to have it be regular and cyclical. I can't speak.
Right. There's a current Alzheimer's state plan. We were just the last one to come up with it, which is 2020. So there is one now, but the Alzheimer's Association recommends not having not fully implemented, no. And most aren't, but we try to get as many accomplished as possible. But what we were talking about is the having Alzheimer's Disease Council here in Kansas that would renew and refresh the state plan every 3 to 4 years. So.
Okay.
So it's basically an opportunity to build on the strength of you've got a plan. So what are you going to do with it? Yeah.
Yeah. So we get that in there somewhere.
Yep. We'll add that into the opportunities.
Thank you. Thank you.
Annette Graham with the Kansas Association of Agencies on Aging. Question on our SWOT analysis that would look like that this group is only working on issues for older adults who have Alzheimer's or other age-related mental health conditions. And that doesn't seem on point for what this group should do. I think it should be, when I look back at the task force, it's not just for individuals who have dementia or mental health issues, it's for older adults and serving older adults. So that's just a question that I think we might want to address and make
Annette,
this better.
Yeah, a reminder that this is just the one that you looked at. You did several topics. So this is just the one topic. So thank you for asking that. This was not your full SWOT analysis that you all did. We can go ahead and send that out too. We took the snapshot of this particular topic since this is what you're talking about today. But that's, yeah, and thanks for raising that, because I should have clarified that earlier as well. So I think you did 4 Yeah.
Yeah.
On those.
I appreciate that because I wasn't involved in that first one, so that's what I was thinking too. I'm glad somebody raised the question. So
Yeah. So there you did the same thing for, remember the other, all the topics that this working group has. You did the same. This just happened to be the first one you worked on because it's the first topic. You also did one for rebalancing home and community-based services, for senior day resources, and for funding and implementation of the Kansas Senior Care Act. So those are the ones. And then the other working groups have different, they've done similar things as well with some of the other main topics. So, but Annette, thank you for pointing that out because in sort of a reminder for this working group overall, the strategy, and I think it's actually down here. Oh, I don't think I shared it on the screen, but if you, we can resend it as well, sort of the schedule for all the upcoming meetings. The strategy has been to talk about a topic, ask about other information you may need, and then spend the next meeting developing recommendations and or additional recommendations and thinking about them in the context of the ones you've already seen from the task force about that topic, then move to the next topic, learn more, build up your information base, develop recommendations, and then once you get through all 4 of those topics, then you'll be going back to all the recommendations again and starting to prioritize and decide this is the ones. Now that we think of all these things together, to Annette's point, they're not just, it's not just within the narrow silo of just this issue. What are the recommendations that we really want to put forth and really want to make sure that the task force sees? So thanks for that, Annette. That was very helpful. I didn't do a very good job setting up our discussion today, in particular the SWOT analysis. Any other thoughts on the SWOT analysis overall? And then I'll ask Emma to share like what we're going to do with this so that hopefully it'll help you. It'll be a tool that'll help us think through some of those other recommendations. Okay, Emma, I'm going to stop sharing and allow you to, before we get into this, I want to make sure I didn't miss any. Yes, others were asking the same question. So many people are thinking it. You also have another thanks in the chat for Annette asking that question. So what we're going to send you, and probably later today, is a tool to start thinking about additional recommendations. We'll also send out what we just worked on and the other recommendations that you've seen from the task force and some of the follow-up questions and resources that you want to have. But we're also going to send out a snapshot of not a snapshot, a extrapolation, I suppose, or expansion on that SWOT analysis. So we think of the SWOT as sort of like a 2x2 of strengths, opportunities, weaknesses, and threats. And this is the opportunity to think about strategies or potential recommendations that will account for all your thoughts you had about opportunities and strengths and weaknesses and threats. So, for example, this page shows you they'll have an example to look at. All right, what is a strength that could help take advantage of an opportunity? So, what's an opportunity that we can say this we have a great opportunity for because we already have this as a strength. So the example that we just talked about with the Alzheimer's disease state plan, for example, would be we've got the Alzheimer's disease state plan, and the opportunity is to develop this council to build on that, for example. And we've already talked about that one. So, but that's one example. Scroll down if we've got some others. Others here are really to look at what are opportunities that can help you overcome weaknesses. So if you thought about a weakness, on the same list of opportunities, is there a connection there that could really help develop a potential recommendation? You'll see that probably many of the things when you think about recommendations will come from your opportunities list because a lot of times we think of those in terms of things that are almost pre-recommendations already. The idea of this tool is not to force you to only think about recommendations that fit into this particular model, but it is to help you all think through and make sure that if you have identified something as a real key weakness or a threat later as well, that we've at least thought through the opportunities or what recommendations you might have to address those. So This will be something we'll ask you to work on between now and the next meeting, but it'll be also something we do as a group in the next meeting. It's actually using this tool to try to develop additional recommendations that address the weaknesses, threats, build upon the opportunities, etc. So there's 4 of these: threat strength strategy, strengths to avoid threats, and then this is the one that's hard, right? How do you minimize weaknesses and avoid threats? So the test, it's not a test to try to make sure you can fill in all these boxes or anything like that. It really is just a tool to help you all think about recommendations. And if you have some recommendation that you can't figure out which box it goes in, that's okay too. Just come thinking about recommendations that'll be helpful to address the overall topic. Make sense? Any questions about this? If not, thanks. Well, thanks, Emma. Thanks for sharing that. Annette, I think.
Yeah, Annette, the Association of Area Agencies on Aging. Is this something you're going to be sending out to us to be working on for a meeting next week?
Yes, we will send that by email to you today, later today, probably today, because it's our meeting, and the next thing I wanted to talk about is our administrative updates. The next meeting is actually scheduled next week, so you guys have a quick turnaround for this meeting. I did have one question for you all, and this will be a question I follow up with Sarah and Senator O'Shea, who are the co-chairs. This meeting is always scheduled for 9 to 10:30. And all the various working group meetings are scheduled from 9 to 10:30. Next week on January 28th, it just happens to be a board meeting for the Kansas Health Institute, and I typically would be at that, and Hina is still not quite back from her time away. Would there be any flexibility at all to move the time for this meeting to the afternoon? If not, that's okay. We'll figure out a way. KHI, we've got other folks can help facilitate it, or I might be able to pop out of the board meeting as well. But I wanted to see if that was even an option before we explored that with the co-chairs. Would afternoon be a problem for anybody?
What time are you thinking? Sorry, this is Sarah Schlitter. What time are you thinking?
Because we're talking about an hour and a half, probably in the 2 o'clock time frame, 1:32. What do y'all think? And if that's not, we can make it 9 o'clock work. So if it's just not feasible, please don't hesitate to let us know. But if we think 2 o'clock, would 2 o'clock be feasible for folks?
I could do 1:30 or 2. I do have something at 3:30, but I could make that work.
How about others? Generally okay? Everybody loves Friday afternoon meetings.
The Mowbray, Kansas Healthcare. I already have a 1:30 meeting on Friday, the 28th.
Okay.
But I'm one cog in the wheel, so.
Does look like 1:30 kind of works better for a lot of folks than 2, if we were to do that. So we couldn't have, some folks couldn't participate the whole afternoon. Would the morning work for everyone still? Everyone who's on this call, would the 9 o'clock time work for everyone? Okay.
Carrie, this is Kendra Baldridge from KDHE. I have a meeting every Monday, Wednesday, Friday until 9:30 that's COVID related. That's why I was late this morning. And it's a meeting that I really can't miss. If I need to, I've tried to figure out backups for it so I can be on this one. But there's that.
Okay. Well, why don't
again, I'm one cog in the wheel. So.
No worries. And the legislature was in session this morning. The Senate was in session this morning. So our Senator O'Shea wasn't able to join, but that's not typical on a Friday. So that's not usually an issue. So why don't we, for now, plan to still say 9 o'clock? And if we just can't figure something else out on the KHI side, we'll reach out and maybe do try to see if 1:30 would still work for the majority of the group. But we will plan on 9 o'clock. That's still on everybody's calendars. That seems probably to be the best way to go. Any other questions or any other thoughts for today or other information that you'd like before the next meeting? Okay. Wow. Looks like we ended right on time. Thanks to everyone, and thanks for folks joining us who are watching on YouTube or on Harmony. Appreciate it, and we look forward to seeing you all in the next meeting. Have a great weekend.
Thanks, Carrie.
Bye-bye. Thank you.